The back and forth that I have with a lot of these DONs is just exhausting and tiring and annoying. Hi guys, welcome back to another video. My name is Laurie. If you are new here, I am a family nurse practitioner, and today's video is going to be pros and cons of working in the nursing home setting if you are a nurse practitioner. Now, these pros and cons are my experience. I have been working in the nursing home setting now for 2 solid years, and I think by now I definitely know what I absolutely hate versus what I am okay with. So I'm going to share my pros and cons with you. It might not be the same for you if you have worked in a nursing home setting, or even if you are thinking about working in the nursing home setting as a nurse practitioner. Some of my cons will be your pro. But first, I am going to announce the 2 winners for the Living My Best Life planner that I told you guys I was going to do a giveaway with. So the first name is Yanni Melanin, and the second winner is Rose Germain. So Yanni Melanin and Rose Germain, comment down below on this video and I will make arrangement in how to ship you your Best Life planner. The first con for me, and let me say this now, I have way more cons than I have pros. And when I kind of sat down to write them out, I was like, oh my goodness. The first one is patients not being adequately cared for. I don't know how to put this nicely or how to say this without offending anyone that works in any facility like this, but I will tell you that I go to a lot of nursing home setting, and it is across the board with some of the lack of care that a lot of these patients get, and it is horrible. And I hate to see it. You guys also know that I do wound care, and when I go and I do my wound care patients, it is just horrendous to see how patients are swimming in their own body excrements. It's terrible. Last week when I went to go do my wound care rounds, I had this one lady, 80-something-year-old lady, and they told me that she had a leg wound. And I said, what about her butt? And they're like, no, she doesn't have anything on her butt. She was a new admission the 2 days before. And I said, okay, let's just turn her just to look. When I tell you, I rolled her over, she was soaked through to the mattress. And then when I said to her, do you know when you have to go? She said, yes, I called them multiple times. I have been asking since the night before to be cleaned up. And they keep saying, they're coming, and nobody ever came. When I tell you I was so angry, I was so angry. And this is something that I see over and over and over and over again. And when you bring it up, I think one of my videos, somebody said, are you reporting this? You report till you're blue in the face, honey. At some point, you report till you're blue in the face. And I think what's going on in a nursing home setting, they're I don't want to say that they're up there against a rock and a hard place, because on one hand, a lot of folks don't want to work in these facilities, and they can't. Well, that's what I've heard somebody said before. We can't just fire everyone, and then what's going to happen? But my con number 2 is the multiple phone calls that I receive morning, noon, night, sun up to sundown, 365 days of the year. I get phone calls about whatever is going on with my patient. So if you are a nurse practitioner and you're working with a physician, you're the provider, so they're going to call you. Whatever is going on with your patient, they're going to call you. But the thing is, for me and the job that I am in, a lot of the facilities that I go to don't have like a night coverage or weekend coverage. One of the facilities that I do go to has a weekend coverage, not a night coverage. So if it's during the week and it's nighttime and something happens to the patient, they're gonna call me. But on the weekends, they will call the weekend coverage. And one of the things in the nursing home setting is that I know a lot of the DONs or their protocol, they tell them you have to call the physician because of anything that's going on with a patient, and that's their protocol. That's fine. I was dealing with a director of nursing who told the nurses that they should call the provider if the patient's systolic blood pressure was over 140. That's fine, but why call me before you administer his regular morning medication? So I was just getting back to back phone calls, and every single resident whose blood pressure was 140. And then the question I would ask is, did the patient receive their blood pressure meds? The answer would always be no. And then I'm like, so what is the phone call about? And I wasn't blaming the nurses. They were doing their job. They were doing what they were told to do. But this is where some of the things that some of the DONs do, and I'll get to that in a minute, is just crazy and mind-boggling to me. Now, if the blood pressure is not going down, a phone call is definitely warranted at that point. Con number 3, let's get into this whole red tape with the DONs. Now, if in these nursing home facilities, they have directors of nurses in the building, and their job is to oversee everything. And one of their jobs, don't let them fool you, is to keep the residents in that building. They don't want patients to constantly being transferred to the hospital, because if patients are constantly transferred to the hospital, they lose money. They lose money. I understand a lot of DONs have a boss and they have somebody that they need to respond to and answer to. That is totally fine. In my experience, a lot of the DONs that I have worked with, and not all of them because I've worked with great ones, are their lines are blurred with them thinking that they are the doctor, they're the provider, and not the director of nursing for the building. And what I mean by that is, I had situations where director of nursing were ordering medication on patients because they think that that's what the patient should have, and then they'll put it under my name, and I'm like, I am not signing off on that because I never authorized the patient to get that. Or I will get the constant pushback of them saying, well, this patient don't need to go to the hospital. I'm gonna give you guys an example, like something happened to me. I had a patient one time and the nurse called me around midnight and said the patient wasn't doing good, but from during the daytime, I think around 4 o'clock or so, they said he wasn't really doing good, but he was still coherent and everything like that. I had ordered some stat labs, some stat chest x-ray, and I already told you guys in the nursing home setting, stat means 8 hours, 6 hours sometimes. So around midnight, the nurse calls me back, and the night shift nurse, and she's like, Lori, this man really don't look good. He's very lethargic. His SpO2 is going down, all of that. And I said, did they do the x-ray? She was like, no, nobody came. I said, did they draw the labs? They drew the labs, but there's no results. And I'm like, he's lethargic. He's not really waking up. I'm like, you know what? He needs to go to the hospital because he's not maintaining his O2. She was like, okay. Now the nurse in the nursing home setting, if you are a nurse, you have to let your director of nursing know anytime you're sending a patient to the hospital. So I guess she had to call the DON, and the DON, I guess, wasn't having it. So she calls me and says, why are you sending this patient out? And I explained, even though I was like, I don't even know why I'm explaining nothing to this lady, but I explained to her why I was sending that patient to the hospital. And she said to me, well, the patient was doing fine. And I said, are you in the building currently? It's 12 o'clock at night. Aren't you at home? She says, yes, she's at home. But when she left at 6 or 7 o'clock, the patient was fine. I'm like, are you listening to yourself? 6 o'clock and it's midnight, 6 hours ago. You think nothing can happen within a 6-hour block of a patient going downhill? And I said, you know what? He's going to the hospital. That is my order. So do with it what you want to do with it. But I am about to put the order in the computer right now that my decision was to send the patient to the hospital because I think that the patient is in imminent danger and he needs to go to the hospital. Then she was like, okay, I'm going to call you back because I'm going to call the supervisor at night. At this point, I'm like, why is she calling me back? Because I already said I'm not changing my mind. So she goes, calls the supervisor at night, telling me that she wanted the supervisor to assess the patient themselves because that nurse is a new nurse. What? I don't care if she's a new nurse. She answered all my questions appropriately of how the patient was looking. And in my clinical judgment, I said the patient should go to the hospital. I washed my hands of it. I put the order in the computer and I said, if anything happens, you can delete my order, but it's going to show that I ordered for the patient to go to the hospital. And I said, after this point, you don't need to call me anymore. You can call my boss and wake him up out of his bed because I said, send the patient to the hospital. Long story short, patient went to the hospital, intubated, on a ventilator. The back and forth that I have with a lot of these DONs is just exhausting and tiring and annoying. And I know sometimes patients don't have to go to the hospital, and some nurses in the nursing home setting get nervous and say, oh my God, this patient is going down. And some of the times I get it, they don't have to go. But con number 4 for me is definitely driving, the commuting. I hate to drive, and this might be a pro for you, but I don't like driving around. And if you work in the nursing home setting, if you work with a primary physician and they have patients in the nursing home, they typically have patients scattered in different nursing homes. They normally don't have patients in the same, all their patients is not in the same nursing home. They're all over. So I am driving all over the Metro Detroit area. I don't like driving in the snow. I don't like driving at night. I don't really like to drive, period. Con number 5 for me is the fact that these nursing home buildings have 0 emergent supplies. And when I say 0, I mean 0. I understand that it's a nursing home setting, but I don't know if the laws need to change or regulations need to change and they need to have certain things. But I was at the building one day to do wound care. He was not my patient, and I realized that the patient was not going to be doing well, and I'm like, this patient is going to code. You guys need to 911 him out of here. When I realized that the patient is going to have to be coded, chest compression and all, and I said, okay, bring your crash cards, because this was the first time I was ever in a code situation in a nursing home. And when the crash card came, there was nothing in the crash card. I'm like, what is this for? There was nothing in the crash card but the board that goes behind their back and nails the cannula tube in. I'm like, what are we doing? There you have it. 5 cons for me. And like I said, this is my personal experience. It might be different for you, but this has been my experience for 2 years. So let's get into these pros. Pro number 1 is the flexibility. When I tell you, I have never worked a job that is more flexible than this in all my life. It is the most flexible scheduling job that I've ever had. What I mean by that is, because I work in a nursing home and I see patients, it doesn't matter how many hours I work, I just have to see a certain amount of patients per day when I see my regular patients. When I do wound care, that's out the water, because any given day, sometimes on wound care rounds, I will see 30, sometimes I will see 15. It just depends on how many wound care patients they have in the building that day. But I can go whenever time I want, I can stay for however time I want, and I can go and come as I please, and that is it. So it is very, very flexible. And when I first started this job, that was one of the big reasons why I stayed, because within the first 6 months, I was going to quit. Pro number 2 is the continuity of care. So the continuity of care that I have with the patients is just amazing. Of course, because they are my patients, I've been working with them now for a full 2 years, and I know them. If I go into one of the buildings and Miss B, there's a hair that's out of place on Miss B's head, I know something is wrong with her. And I actually like that, because I get a sense that I know what's going on with them. If anything, I know that something is not right, and I can start taking action quite swiftly. So pro number 3 is definitely another one that I didn't think, and I'm not sentimental, the bond that you form with a lot of these residents. Like, I have been caring for some of these residents for 2 years. It's like I've become some of their granddaughter. They've become my grandmother, my grandfather, you know, my auntie. So when I go in the building and I'm chit-chatting it up with them and you're bonding with them, it's an amazing feeling, and they like to see you come and just light up when they see you, and that is just amazing. So the bond that I am formulating with them is just amazing, and that's a definite pro for me. So that's it. Those are my top cons and my top pros for working in the nursing home setting as a nurse practitioner. I hope that this enlighten you a little bit in some of the things that I face on a day-to-day basis. Let me know in the comments down below if you are a nurse practitioner who worked in a nursing home setting and you resonate with any of these pros or any of these cons for me. And if you are a NP student, what are your thoughts? Did I scare you? I hope I didn't scare you. Thank you guys so much for watching. Again, do not forget to like, comment, and subscribe to the channel, and I will catch you guys up on my next video. Bye guys.